Hello, everyone. So we're going to continue with medications for irritable bowel syndrome. So irritable bowel syndrome, IBS, basically it's a chronic inflammation of the GI system. There's have been multiple protocols to treat it, and so far, uh, there's nothing set on stone. So let's go over here before I go into detail about it. So regarding the irritable bowel syndrome, it's more common on Americans, more common on female Americans. Patients gonna complain about abdominal cramp, and when we run tests on them and do a physical assessment, we don't see something obvious. It's just the pain there, and because this is an inflammation of GI system, we can see diarrhea, we can see constipation, we can see both, and there's a lot of pain. Usually, the way we get to a diagnosis of irritable bowel syndrome, IBS, is because the symptoms have been there for 12 weeks in 1 year. So it's a clinical diagnosis not made by labs or imaging studies. It's just based on the clinical presentation and the time frame that it has been there. And like I was telling you, so far the American College of Gastroenterology has nothing specific regarding protocols. They don't favor antispasmodics like, okay, this is a treatment choice, forming agents as treatment choice, antidiarrheals or tricyclic antidepressants. Uh, they even say, hey, sometimes we have seen that antibiotics and acid suppressants can work for irritable bowel syndrome. So basically, when we have a patient with IBS, with a diagnosis of IBS, we need to play with drugs and find something that benefits the patient. And the treatment is not the same from patient to patient with IBS. So far, drugs that are very specific for IBS is alloxitron. And again, you see the citron ending. So it comes from a family of ondansetron, the serotonin antagonist. So far, neurotransmitters. Serotonin is the main neurotransmitter for the GI system. So this is a reason that we have played more antagonists in serotonin with the IBS patients. So far, alloxitron, it will be the most common drug used for IBS, and it's approved for women only. To be honest, I'm not sure exactly how and why it's only for women, since it's a serotonin antagonist, a serotonin blocker. Uh, I will imagine that it will be the same for male patients. The problem with dosentron, we need to do a close follow-up since it can lead for constipation or even ischemic colitis. Ischemic means a necrosis of the tissue. So when this patient is with alloxitron, we need to make sure that we do a proper detailed triage and physical assessment of the GI system. Also, we have lubiprostone, amitisa. Um, this medication is used on IBS that favors constipation. And again, is used on females 18 years of age or older. Usually when we see IBS more commonly in the adult, it's not that common on the teenager, even though we have seen an increase in the last few years. Benefits are, well, we can say fair. It's not the best drug out there for IBS. Unfortunately, it comes back, but from all the drugs that we have, is the one that has the better benefits, taking that inflammation away. Also, we have tegaserot or Cellnorm. This is a short-term therapy um, for IBS. And the reason that is short-term is because it has cardiac effects. It can affect the heart and produce arrhythmias. So we have to, with tegaserot, it's for female patients, adults, but younger than 55. So here we have a very specific number, 55 years of age. The thing is, females, due to their menstrual cycle and hormones, they have an extra protective layer, to put it in one way, with the heart. Estrogen protects the heart. So as long as they have a menstrual cycle, as long as they're not in menopause, estrogen is going to take care of the heart, and we can give this medication, tegaserot, to the female patient without worrying about a cardiotoxicity effect. After 55, estrogen levels goes down, amenorrhea shows up, um, basically menopause, and we lose the estrogen, we lose that extra layer of protection from the heart coming from estrogen. And now the adverse effect, that's cardiotoxicity, is higher for females taking this medication. So tegaserot, if we're gonna ask any question regarding about it, it has to do with the age. And the questions, they're not gonna be that obvious. So starting at 55, they might say a post-menopausic patient. So that's a hint like, hey, this is about 50 years of age, contraindicated. Okay, from here, we're gonna jump to inflammatory bowel disease, IBD. And this one is caused by an exaggerated immune response to normal bowel flora. So here we have a reaction from the body attacking the bacteria that resides normally in our gut. So here we have a Crohn's disease, where we have, it says transmural inflammation. That means the whole tissue of the intestine is affected and affect all parts of the GI tract. You know, unlike IBS, it's a lower GI part, that means the intestine, the colon. When Crohn's disease can go all the way from the esophagus to the rectum. So that's a big difference between IBS and IBD. Crohn's disease affects the whole GI system and affects the whole wall of the tissue. Also, we have ulcerative colitis as part of the IBA syndromes, where here we have same thing, inflammation of the mucosa, mucosa of the colon and rectum, and this inflammation is chronic. Inflammation eventually starts to bleed, so we have a constant bleeding that may require hospitalization depending on how long the bleeding has been going and the type of anemia that we have. Unfortunately, IBD, because it's an immune response to our normal flora, we have no specific medication, so we treat it as an autoimmune disease. So it's gonna be common for you to read other books where they're gonna say Crohn's disease or ulcerative ulcer, ulcerative colitis are autoimmune diseases. So based on that principle, we have this group of drugs, the 5-aminosalicylates, which is immune suppressant, glucocorticoids, we just mentioned a couple of chapters ago, that they block the immune system. We have immune suppressants, usually medications for autoimmune disorders like azathioprine, that they can be used, immune modulators that can control the inflammation. Again, it's remember we mentioned immune modulators, then in MAP, monoclonal antibodies. So they're antibodies designed to attack the antibodies producing the inflammation, and antibiotics. like a metronidazole. Metronidazole, you're gonna, so far you have hearing that is very good for GI infections. So if this is a immune reaction to the normal flora of the intestine, the metronidazole can be an option to decrease that response, to decrease that inflammation. So let's do a quick review of all of them. 5-aminosalicylates. They reduce the inflammation and they suppress, right here, keywords, prostaglandin synthesis. So that means if I block prostaglandin, I take the pain away. I take the pain away. I take the inflammation away. The only adverse effect that you have to see right away, the stomach uses prostaglandins to make that mucus layer for protection. So that means that if this patient is taking sulfasalazine as for IBD, we need to do follow-ups of the integrity of the gastric tissue. Make sure the patient doesn't have gastritis or an ulcer when they're taking this drug. And if they don't have that, while they take the medication, we have to make sure that they don't develop gastritis, GERD, or peptic ulcers. Glucocorticoids, as you can see, we have glucosinate, and this is the one of two glucocorticoids or steroids that don't end in one. We have dexamethasone, prednisolone, hydrocortisone, and so on. And all of them I have been emphasizing then N in one, N in one. Budesonide, this is one of two that don't end in one. So it's a glucocorticoid, and we mentioned glucocorticoids, they suppress the immune system. So that means that they suppress prostaglandins. So same thing as 5-aminosalicylates. We need to take care of the integrity of the gastric tissue. That will be the follow-ups, besides, the signs and symptoms of Crohn's. As a hormone, you're gonna see adrenal suppression. The adrenal gland is gonna start working because again, we're providing already a synthetic hormone that looks like cortisol. So like any tissue, oh, I don't need to do nothing, then you know what? I'm gonna relax, that's it. Budesonide is doing what cortisol does, so I don't need to make it. So we need to be careful with this suppression. What is the meaning regarding teaching, regarding adrenal suppression? That when we remove budesonide from the patient, we don't do it all of a sudden because the adrenal gland is not gonna respond right away. So we need to taper down the medication. That way the adrenal gland can start making cortisol little by little. So that's the teaching that we have when it says adrenal suppression. Same thing, a patient's gonna have osteoporosis because glucocorticoids, they interfere with calcium absorption, increase infections, and we mentioned this, glucocorticoids, they inhibit the immune system. So here we're blocking the immune system to stop the signs and symptoms of Crohn's. But if the patient starts complaining, I have a sore throat, I think I have a fever, I have body aches, then we need to reevaluate that patient and change the treatment and start treating them for infection. And also we mentioned when a patient takes glucocorticoids for a long period of time, they're gonna develop Cushing's syndrome. And it's right here. Regarding immunosuppressants, so just like the name states, they suppress the immune system and they're very aggressive doing that. So here we have azathioprine and mercaptopurine. So basically how they do it, how they work, they block the proteins to make white blood cells. So if I don't have proteins to make white blood cells, I'm not gonna make white blood cells, and the count goes down. So if I don't have white blood cells, this immune response to the intestinal flora is not gonna happen, and the signs and symptoms of Crohn's disease are gonna go away. This medication takes up to 6 months to start working properly. It's used only on patients that don't respond to other treatments. because again, I'm suppressing the immune system. So if I give this medication and the effects they last up to 6 months, infections may happen. So in that period of time, we need to do a constant evaluation of the patient looking for signs of infection. And the other one that states pancreatitis. Immunosuppressants, they can irritate the pancreas and produce pancreatitis. Now, immunomodulators, they're less aggressive than immunosuppressant. And I told you all immunomodulators, they end in MAP, monoclonal antibodies or mono antibodies. And this is an antibody that is designed to attack the antibodies attacking the intestine. It's like a tongue twister. Antibodies designed to attack the antibodies attacking the GI system, attacking the walls of the GI system. Same thing, we will have a response that is not as aggressive. And regarding adverse effects, it can be also immune suppression, not as severe as the other ones, glucocorticoids or immunosuppressants, but still we have a risk of immune suppression with immunomodulators. The type of infections that we see right here, they're going to be very specific, and they're going to be gram-negative infections. So we're talking about Salmonella, Shigella, E. coli, Campylobacter, and Clostridium. Those are the most common infections of the GI system. With the other ones, glucocorticoids, immunosuppressants, is every type of infection, gram-negative, gram-positive, parasite, fungus, is opportunistic infections. We can use antibiotics, like we mentioned, metronidazole is being the most common one, followed by ciprofloxacin. And again, it's because with these two type of antibiotics, we can reduce the amount of flora on the gut, and that will reduce the response from the immune system attacking that bacteria. Optional medications that we can use is what we call the prokinetic agents. Remember, regarding inflammation, any type of inflammation, not just the ones we were mentioning here, any type of inflammation is going to have 5 signs that you're going to be able to identify. So one is well, edema, redness, swelling, pain, and loss of function. So those are the 5 signs of inflammation. Again, let me put them right here. So I mentioned redness, swelling, heat, loss of function, and by heat is increase temperature of the area, not the whole body. Loss of function, and I'm missing one. So, man, I just said all 5 of them. I can't see to see the recording again. So okay, I owe you the other one. But the key fact here is loss of function as part of the inflammation process, loss of function. So we need prokinetic agents to stimulate the GI system to start moving again. Regarding prokinetics, we mentioned metoclopramide is the best drug out there. Besides blocking dopamine in the vomiting center, I told you it also stimulates peristalsis. So on Crohn's disease, ulcerative colitis, we have inflammation, the intestine is not moving. Reglan or metoclopramide will help increase peristalsis, and that will help also take the signs and symptoms away. Regarding prokinetics, they block dopamine, and the long-term use of dopamine blockers, and again, this is a review for the antipsychotic drugs, is tardive dyskinesia. Okay, so that will be it for this chapter. I'll be seeing you soon.